We could go with the Q&A now. Some people come with NIH score of 0 to 5, and their CT cerebral angiography shows an LVO. Professor, what do you think is your opinion from one of the attendants? Is it considered the risk to lose thrombectomy or consider a clinical image mismatch?
So that will always depend on exactly what the symptoms are. You know, an NIH of 5 with aphasia is going to be different than a little bit of slurred speech, a little bit of numbness, etc. And so there's always going to be a clinical assessment as part of your assessment. As I alluded to in my talk, my approach is to assess for disability first. And then if they're disabled, that's straightforward. I would mostly, if I'm going to give, if they had an M1 or an M2 occlusion, I would mostly be giving thrombolysis and then going to EVT. If it's more distal, you may just use thrombolysis. If they, however, have an M1 occlusion and an NIH of 2 and they're not disabled, I personally would randomize them in tempo and I would put them on our acute neurology unit. I would have close monitoring and watch them for any deterioration. You know, some people would use CT perfusion. I think the jury's still out. I certainly will use collaterals, will help me make a decision. We use multi-phase CTA in Calgary a lot. And I usually find that as useful as CT perfusion. So hopefully that answers your question.
Thrombolysis effective beyond the first 3 hours in patients where a viable number is identified using the perfusion imaging?
Yeah, I mean, certainly you know, in Calgary for a long time, we've always touted the sort of tissue window rather than time window. And there are a variety of ways of doing that. The easiest would be CT perfusion. And that's because you can buy automated software that has some limitations, but if you are not an expert, if you know, you treat stroke patients relatively rarely outside of a center of expertise, then that can be very helpful. We certainly use multi-phase CTA to look for collaterals, to basically look for tissue that's at risk but not dead yet. And so I've treated somebody out to 36 hours from onset because they clearly showed that they still have tissue at risk, and we made them better. And so, you know, are we always right? No, but certainly now I don't always use time. Time is often one of the factors that I use, but it's not the only thing.
Is intra-arterial thrombolysis, does it have a more safety efficacy compared with IVTP?
I think you have to remember that EVT is not necessarily safer than IV thrombolysis. The risk of hemorrhage is very hard to eke out of any of the trials. Like some of the direct to EVT trials that were recently published, it certainly doesn't look overwhelming that the risk of hemorrhage is much lower if you go direct to EVT. So I certainly don't use that as a reason all the time. Most of the time, I would prefer to give them standard of care and go IV TPA unless you know they've had a recent GI bleed or something that makes me not want to give them thrombolysis. But if they're kind of a standard stroke patient, I would always give them thrombolysis if I can.
With a neurological fallout with the TIA, can it recover completely, or are some symptoms permanent?
If a TIA leaves a deficit, it has not been a TIA, it's an infarction by definition. So it's by definition, a TIA doesn't leave a trace of infarction, neither clinically nor in MRI or CT.
Saying I have been seeing 2 cases where neurological symptoms have worsened following the thrombolysis. What could be the reason for this?
I mean, I think there's always multiple reasons for people getting worse after thrombolysis. Hemorrhage is obviously a big reason that you can get worse, an intracranial hemorrhage. Sometimes you can move the clot distally actually with thrombolysis. So they were surviving on their collaterals. You give them thrombolysis, the clot moves slightly further out, and unfortunately that means they get more symptoms. And you know, I think there are multiple reasons. There's failure of collaterals that actually have nothing to do with thrombolysis. So I think there are a multitude of reasons. If somebody worsens post thrombolysis, I will always do a CT, CTA and see what's happening. So I think you need to understand in the individual case what's happening.
So there is I guess this is for Professor Helmut. Do you need to lower LDL less than 70 in patients above 75 years of age for prevention?
I think so. They were part of this study, and there's no reason, as in other forms of stroke treatment, where less and less, we don't no longer accept an age limit that we say above age X, we don't treat the patient because it doesn't matter. So I think there's no difference for one being 60 or 70 or 80-year-old regarding the LDL target.
There is a question about COVID. Of course, we are in the era of COVID. I guess we can hear also Professor Helmut, if the dual antiplatelet is, if the treatment is also valid for COVID patients, especially if they are having low molecular weight enoxaparin or any other anticoagulant. So
the setting would be a stroke in a COVID-19 sick, so in a COVID patient. That's probably the setting. Stroke in a COVID patient.
Exactly.
Although that's very difficult, difficult to answer. So I would say I mean, first of all, our impression is, and the data also, I mean, there is a slight increase to suffer a stroke in severely sick COVID patients, but it's a minor problem. It's not really that we see it every day. But I do not think any reason to behave differently in a COVID patient suffering a stroke than in another patient suffering a stroke, except for you have, of course, extraordinary circumstances with intensive care treatment and bleedings going on or whatever. And of course, you would have to change this approach. But just only having COVID would not change my strategy of treating a stroke or doing secondary prevention.
Okay. Which I guess this is also for Professor Helmut. Which risk factors for atherosclerosis and cardiac? Where is the question? Which risk factor for atherosclerosis and cardiac disease should be identified in medical history of patients with suspected ischemic stroke?
Of course, arterial hypertension, diabetes, smoking, and history of other vascular events, cardiac, neurological, or peripheral. That's the basic things of history taking.
Okay. Also for Professor Helmut, regarding aspirin resistance.
That's a big question, yes. I mean, that's a discussion going on for quite some time. And the German guidelines, but we had this discussion here in Germany again, and the result of the discussion is that we do not recommend routine testing for aspirin resistance before giving it, because it was not part of any of the studies in the past showing that aspirin works, and it's of questionable prospective clinical relevance. And even if a patient suffers an ischemic event under aspirin treatment, there's no indication to test him for aspirin resistance. That's the current expert opinion, unanimous opinion in Germany on aspirin testing. I mean, you can do it differently if you believe in it, but the guidelines do not consider it necessary or recommended.
I I guess in the same context also, regarding the use of dual antiplatelet for longer period or even for life, if the patient is having recurrent stroke while he is using antiplatelet, single antiplatelet, or you just change the antiplatelet?
So, as I showed, there is a risk in doing dual antiplatelet treatment, and the longer you take it, the higher the risk. And that's why the guidelines are so cautious about it and restrict it to 21 or 30 days. And that's what I would do. I mean, I'm very much aware of many patients being anxious to reducing a double antiplatelet regimen to monotherapy. And that's probably a risk for real life, that many of them, not being followed and being anxious, never change the double antiplatelet regimen. And so in real life, the benefit may be less than in the studies focusing the first 90 days. So, but there's a clear risk in double antiplatelet treatment, so don't give it too long. That's what I can say.
I mean, if the patient developed already stroke in one antiplatelet, would you switch to another antiplatelet, or you will give a dual for a while? Or
I would treat him as he would have the first stroke. So if he has a high risk TIA, if he has had a high risk TIA, or I'm pretty sure that's an atherosclerotic event, I would treat him with double antiplatelet treatment for 21 days.
Any feedback about tenecteplase? Because we are coming into the era of the tenecteplase.
Very promising, but very promising, and probably the thrombolysis of the future. But it's in Germany, it's not available. Is it available in Egypt?
No.
Yeah. Very promising, but still waiting.
Also, the timing of the start of the anticoagulation after stroke in cases of AFib.
Depends on the size of the stroke. Between day 1 in TIAs or day 14 in let's say, larger strokes. But there's no firm rule. It's a matter of feeling. So it's 1, 3, 6, 9, 14 days, depending on the size of the stroke.
Patient with long-standing diabetes mellitus who got multiple infarctions shown on MRI, but almost not obvious affection or motor sensory deficit. Should this patient be pushed through undergoing removal of the infarction? I guess he's meaning the clot, removal of the clot.
By thrombectomy? Probably, huh?
Yes.
My answer would be yes. If there's no clear contraindication against removing the clot, I would do it, independent of microvascular changes or whatever may be present there, because that's the condition to be prioritized and in the acute setting.
The use of aspirin in the setting of acute stroke is likely to turn an ischemic stroke into a hemorrhagic one. Should it be introduced later instead of and instead use clopidogrel in the initial stage? What's your opinion?
That was the thrombolyzed patient.
He specify he's talking about the setting on acute stroke in general.
So in a patient having been thrombolyzed, I wouldn't use double antiplatelet treatment, because all the studies you saw, the benefit is with early initiation of double antiplatelet treatment. So very early, there's the highest benefit. And of course, after TPA, I wouldn't do it.
Okay. Is COVID vaccine allowed in patients with cerebrovascular accidents not caused by COVID?
Yes, of course. It's allowed, and probably at least as beneficial and as in non-stroke patients, because COVID takes a worse course in patients having had a stroke in previous years. So it's probably a reason to do vaccination instead of not doing it.
TIA with high NIH stroke scale, how commonly seen by you and the approach for imaging and treatment?
Well, that's very rare. I mean, if you mean high 15 or so, that's extremely rare. And yeah, okay, it may happen, but it's very rare. Maybe one in 100 TIAs with a NIH of above 10, then turning out to be a TIA. Very unlikely.
Regarding sickle cell patients with thrombosis, how could you manage?
I think, Professor Hani, this is a question that's probably a question to you, because we almost have no such patients, and I have no personal experience, I must confess. This is a condition that we rarely, very, very rarely see.
Yes, I guess they are, it's not also in Egypt, it's not very frequent. They are seeing cases, especially in the pediatric department. But the most important, I guess, blood transfusion and but during the acute setting, if there is occlusion, probably also they can give. What's your opinion, Dr. Hassam? You give, and also Dr. Scott, Dr. Kotz, you think we can give anticoagulation in the acute setting in these patients?
I also don't really see
thrombolysis is allowed according to the guidelines, but we don't see them. Yes, Professor Kotz, please.
Professor Kotz, what's your experience with such cases?
Professor Kotz, your opinion, please.
We don't see many sickle cases either, so I have no personal experience.
Yeah, same with me.
Okay, so they are becoming very uncommon. Do you recommend the usage of warfarin or other anticoagulation therapy for every AF patient to avoid stroke? I guess this is...
For every AF patient, I mean, that's if you mean patients who never having had any embolic event, of course you have this subgroup of relatively young men having isolated AF without any other risk factors, not having a Chats-Vasc score of 2 or more. Maybe you can exclude them, but in neurology, you almost always see patients having had a symptom attributable to AF, and then there's no doubt that they should be anticoagulated.
Okay, I guess we need to share both of our eminent speakers in this experience, because somebody's asking about the post-COVID vaccination stroke. Do you have any experience in post-COVID?
Yes, I have. I mean, I have been part of a task force even in Germany, and we have published that examining these VITT, vaccinated induced thrombopenic thrombosis. That's the kind of condition the colleague is asking about. So there's no vaccine so far. There's no reports on a higher likelihood of suffering vaccination-induced strokes, except for the thrombotic sinus thrombosis events going together with thrombopenia. And that appears to be restricted to the vaccine by AstraZeneca, the virus vector vaccine offered by AstraZeneca, more women than men, showing sinus thrombosis, thrombopenia, and 30 to 40% fatal outcome. So very severe condition, which is autoimmune, basically. It's a phenomenon very, very similar to the heparin-induced thrombopenia. It's also treated the same way as heparin-induced thrombopenia. But that's the sort of stroke which can be attributed to vaccination. Otherwise, no reports are out reporting more strokes after vaccination.
And your experience, Professor Couch?
Yeah, I have a similar experience. I had a VIT case with a CVST last time I was on service. She actually she was lucky, she did very well. I will say last time I did service, we had just done the elderly COVID vaccinations. And so a third of patients on the stroke service had had a vaccine in the last month, but I didn't have any more patients than I normally had. So I certainly don't think that the arterial strokes were related to the vaccine.
Yeah, in Germany, they started vaccinating the younger half with the AstraZeneca vaccine, and that was retrospectively was a mistake because these complications tend to occur more often in the younger than in the older group.
Yeah.
There's a question regarding the guidelines for Dr. Helmut also. The ischemic cardiomyopathy, you know, there is no clear criteria for in the guidelines when to start anticoagulation. What's your opinion?
In what kind of cardiopathy?
In ischemic cardiopathy with sinus rhythm. You know, whether you really depend on the hypokinetic segment ejection fraction or whatever criteria, when you will start in the heart failure, the anticoagulation.
If the patient has not suffered a stroke or a TIA, I would not start putting him on anticoagulation. I would ask the cardiologist. If he has, I mean, there have been studies in that in the past. It has not been shown that the heart failure, the simple heart failure without atrial fibrillation patients plus strokes benefit from oral anticoagulation. So I wouldn't do it on a routine basis, except for you have other factors involved, such as atrial fibrillation. So heart failure alone is no reason to do anticoagulation.
So there is a question regarding when to resume aspirin in after hemorrhagic transformation in a stroke. Regarding the recurrent TIA, there is evidence for TPA if the MRI is normal. I mean, this is, you know, this is a common situation. I guess this is important to also knowledge to share with our post speakers. I mean, if the patient arrived to the hospital and after half an hour, then he develops the symptoms again, and you are preparing the setting, and then the patient resolve it, and what you will do? Can you hear me?
I'm sorry, I didn't really get the question because it was fragmented somehow acoustically.
Okay, regarding the recurrent TIA or crescendo TIA, you know, sometimes the patient, while he's arriving to the hospital, symptomatology resolved it, and then started to symptoms recurred. And I myself witnessed many of those patients, sometimes up to 6 times, you know, he's coming and going. Would you go for TPA for those patients, or you will do MRI, perfusion, or any more sophisticated investigations?
But the patient has no baseline deficit, huh? It's just
probably you catch him in between. I mean, with a deficit, let's say more 10 or so, or sometimes even 0 in between.
Yes, most of them are lacunes, stuttering lacunes, as we call them, and we would load him with double antiplatelet treatment immediately.
Yes, so you will not go for TPA.
No, if he's back to normal in between the attacks, I would not use TPA.
And you will do immediately MRI, MRA with diffusion and all the setting for the imaging.
Yes, we would do it, but I doubt whether it's really you have to do it. But we would probably do DWI and see whether it already has a structural infarction. But for the treatment decision, I would say that it's not necessary to do MRI in such a case.
Dr. Kautz, what's your opinion regarding these patients?
Yeah, I have thrombolized them when they go back to normal. You know, it really depends on what their clinical characteristics are. Like if they've clearly gone back to normal, I have given thrombolysis for these fluctuating lacunes. I will say that I don't know that it makes any difference whatsoever. my personal experience is that it's 50-50. So 50% of patients do well and 50 don't, whatever you do here. I think it is the last bastion of what we don't know how to treat in stroke. Like I think for acute lacunar strokes, it's hard to know exactly what works.
We noticed, there is a question also, we noticed in our region that actually the intracranial stenosis is quite high, and the extracranial is quite few. Actually, we have from our center even a paper published in Stroke Journal. It's almost 27 intracranial stenosis. The percentage is 27% among Egyptians. So any special consideration in these patients, especially, you know, sometimes we are in the setting of having a total occlusion of the intracranial, chronic, of course, total occlusion of the intracranial part of the internal carotid artery, and the patient is dependent on the collaterals, and he is developing more or less a stroke, which is probably a watershed stroke. Would you go also for TPA? And of course, sometimes we confronted these situations many times. We don't know whether we can go for catheterization, because, you know, sometimes catheterization will make showering of this long segment of chronic thrombus. It's a very awkward situation, actually. Are you facing such situations? I mean, because it's common, the intracranial stenosis here in our region in general, I guess it's quite common.
We see such patients occasionally, but very rarely, because and as you know, in Europe, the pattern is quite opposite. We
Yes.
see more of the extracranial disease and less of the severe intracranial cases. But once in a while we have such cases, and if it's really a chronic occlusion and the patient happens to have watershed infarctions from time to time with good recovery in between, this is one of the very rarely indications for intracranial bypass surgery. That's what we do, let's say, maybe 3 times a year.
But for the acute setting, you will not give TPA.
If it's a severe stroke syndrome, we would give TPA.
Yes.
If it's and the time window and the syndrome is severe enough, we would treat them with TPA. But of course, being in doubt whether this is really, I mean, that's more or less formalistic. Of course, the pathology is probably less likely to be a thrombus, but because we don't know, we would treat him. In doubt, we would treat him with TPA.
And what's your experience, Professor Kautz?
Again, in Canada, we don't see this as much as you would do in sort of the Middle East. It varies from a case to case. If we don't know something's chronic occlusion, clearly we would just go ahead and thrombolize. But yeah, occasionally we have also done IC bypasses in that scenario too.
There is a question, I guess this is for Dr. Helmut. Do you load patients when starting dual antiplatelet in minor stroke?
Yes, we do. We do it following the point approach, but we load them immediately.
Yes. Also, regarding the issue of loading, because, you know, I know this is quite uncommon in neurology, but there is, I remember there is a paper by Dr. Grotta from Texas, and it's a load study, and also we are having some work on this regarding the loading, aiming for treatment of acute stroke, especially in patients who are not likely to have TPA in distant area and rural areas. So, and many actually, especially in Egypt, are doing this policy. I mean, giving sometimes 8 and even 12 tablets, like, you know, the cardiology, and with good results. And actually, you have some publications about this. Would you consider this, especially if TPA is not available, loading with a high dose of antiplatelet, aiming for improving the actual stroke, not for second prevention?
Yes, I would. And this is because the effect of antiplatelet treatment is preventive effect, let's say. It's not stroke treatment, it's prevention of progression or the next stroke. But the effect is largest in the first hours and even diminishes thereafter. So it makes sense to load them immediately. Also, it's not, although the guidelines are very liberal about it, they say you can start with 100 milligram right away, but you can also load them with 300 right away. So it's very liberal, but the pathophysiological concept and also the studies by Peter Rothwell in the past let us believe that the effect is highest in the first hours even, and also days. So it makes sense to load them.
Professor Cox, what's your experience in initial loading with high dosage of clopidogrel, especially if the patient is not having access to TPA?
Yeah, we routinely give at least 300 milligrams. Sometimes I'll give 600 if I really need it loaded fast, if I'm worried. Routinely, our load is 300 of Plavix, yes, and 160 of aspirin. And we always load. My view is there's no point in doing it unless you're going to load.
Yeah, I agree.
Okay. So any news about, this is a very important issue, and actually most of the trials failed, the post-stroke neuroprotective agents?
Nothing new about that. But still trials going on in thrombectomy patients, because that's of course a new field where they may work because the patients are recanalized early. So, but nothing really to report.
Regarding also for Dr. Helmholtz, regarding the dyslipidemia, would you recommend other agents rather than statin, like nexletol or any other agents?
The agent well established is ezetimibe. That's the one, for instance, used in the Treat Stroke to Target trial, TST trial. Ezetimibe is well established. Of course, there are, if you have extreme cases, there are also these new, very new, but extremely expensive kinds of treatment, like PCK9 inhibitors, things like that, extremely expensive and not approved for this indication, for neurological indication so far. So this is certainly nothing to recommend to 400 people in the audience to think about. I mean, ezetimibe and statin as the groundwork.
Any experience with loading of ticagrelor?
Personally, not, no.
Okay. I guess this is most of the questions. So, Dr. Hissam, you have any more questions or comments, or anything you would like to add?
No, thank you. For me, I was very pleased that I was chairman in your presentations, Professor Steinmetz and Professor Kautz, and you really enriched us with your knowledge and your data. And the recent data you have just showed us, and we wish always to have you. Professor Hani could also continue. Please, Professor
Hani. I express my gratitude and pleasure, of course, to have both of you, Professor Kotz from Calgary and Canada, and Professor Helmholtz from Germany, Frankfurt. It's our honor and pleasure. And hopefully next time we will have you both physically in the Middle East, probably in the MENA stroke. We are having in November in Bahrain. You can have it on the screen. Yes, the organizer put the it's our next big event in the region. It will be in November in Bahrain, and hopefully we can, I mean, still we are preparing it as a hybrid, but if things open, we will probably will make it fully physical if it is possible. We hope so. So thank you again, and looking forward to see you more physically next time.
Thank you.
Okay.